Assalamualaikum warahmatullahi wabarakatuh, everyone. Thanks again. So this is the part 2 of the urinary system. So apologies for not having this quite early today because I got something else to do. However, this is the continuation from our previous lecture, and I hope this can help us to further understand how the kidney works, especially in regulating the blood volumes or the excretion of urine, right? So you know that last time we have started with the glomerulus, which is the first location or the first part where we can find the filtration is occurring. And we have shifted to the proximal convoluted tubules. And as I mentioned earlier, and this is where the reabsorption occur. And alta-filtrate in the proximal convoluted tubules or PCT is isosmotic to the blood, and it has a very low osmolality, is around 300 milliosmol per liter. So osmolality here means the concentrations of the dissolved particles or any chemicals. Maybe some of you find it, some minerals like sodium and electrolytes in the serums. All right. So this is the dissolved particles. Means if it's higher sodium or higher ions or electrolytes, means it's is greater osmolality. Okay. So if it's low like this, like 300 milliosmol, so it can be said that this is low osmolality. Right, high osmolality means you have more particles in your serum. Low osmolality means the particles are more diluted. Right, so your blood is like a liquid chemistry set. So it can have a different area with a different concentration of particles or dilute particles or solutes. So the reabsorption of water, of course, this is the water. We can find the sodium and also the chloride being reabsorbed back to the circulatory system to compensate with the needs that is required to maintain the current body status. So the reabsorption of water by osmosis cannot occur without active transport. So this is the prerequisite, and it's achieved by the active transport of sodium out of filtrate. So when it comes from the afferent arterioles, it goes in, and after that, some of them will be selected and pass through the pore, and after that, again, reabsorb or reclaim into the circulation. And loss of the positive charges causes chloride to passively follow the sodium. So sodium chloride, water, what I can say, glucose, amino acids are, the main components that have been reabsorbed at this stage. Some urea or like some bicarbonate also being reabsorbed at this PCT. Okay, and the water then follows salt by the osmosis gradient. So the significance of the PCT reabsorptions, most like around 65% of sodium, potassium, some chlorides, okay, is reabsorbed in the PCT and returned to the bloodstream. Well, the rest, 20% is reabsorbed in the descending loop of Henle, and 85% of the filtered water and salts are reabsorbed in the early nephrons. We already discussed about this in last week, and this is at the constant rate and independent of body hydration's level. And the remaining 50% are reabsorbed variably depending on level of body hydration. Really depends. Okay, if you need more water, like when you're fasting, of course you need to retain more water in the blood, in the system. Okay, concentration gradient in the kidney. So in order for the water to be reabsorbed, the interstitial fluid of kidney must be hypertonic to the ultrafiltrate. All right, so the interstitial fluid of the kidney, the current conditions inside the kidney must be more concentrated than the ultrafiltrate. And this is to allow a difference in the gradient of the of the fluids that is available in the kidney. So that's why we have a different concentration of particles. We call it osmolality, especially those particles are more concentrated if it reach the bottom parts of the loop of Henle. So this is in the medulla part of the kidney, where most of the water being excreted, and also some of the sodium and chloride also being excreted. In other words, the loop of Henle is where the particles being concentrated and the osmolality is increased. So the concentration gradient results in largely from loop of Henle, which allows interaction between descending and ascending limb. So this is an illustration of the loop of Henle. You can see the left-hand side has very thin descending limb, right? On the left-hand side, and you can see on the right-hand side, you can see very thick one, like a bigger diameter, and that's the thick ascending limb. So that's a reason behind this morphology or structure. So we first look at the descending limb loop of Henle. It is interesting that you can find it from the cortex area where the PCT, it passes around 300 milliosmol fluids or ultrafiltrate into the kidney tubules, passing down to the medulla, and you can find the concentration of dissolved particle is increased from 300 to 600. And after that, it become even more concentrated to 800 and 1000. That is because lots of water being excreted or reabsorbed back into the capillary. And this is in the descending limb. And it's quite permeable to the water. It means the tubules, the descending limb loop of Henle is permeable to water, and it's easy for the water to leave the tubules and join or reabsorb into the capillary. Because the deep regions of medulla are hypertonic, water diffuses out or filtrate into the interstitial fluids. So this is true because it's permeable to the water and they are hypertonic. Okay, the medulla deep region at the bottom are hypertonic. So the water needs to leave the tubule, leaving only important ultrafiltrate or maybe some waste molecules inside the descending limb. And this is occurred through the passive diffusion, okay? And this reabsorbed water is then collected by the capillary, to be used by the system again. The right-hand side, okay, which is another side in another region or another part of the loop of Henle, we call it the ascending limb. And this is quite different from the descending limb. Okay, the descending limb is a thin structure, whereas the ascending is bigger in terms of the diameter, and we call it thick ascending limb. And if you can see from the bottom, okay, we started from 300 milliosmol and it reached up to the U-turn part, okay, it's around 1400 milliosmol. It's very concentrated. The deeper they go means the more concentrated particle there will be. So from this side, so that's the the point where they have reached the maximum threshold of the maximum osmolality. Before they move to the ascending limb, you can see it's further allowing more water to go out. I think this is not allowing more water to go out. Instead, they retain lots of water molecule inside it, but they will allow the sodium and also the chloride to leave the tubules. All right, it's the other way around. All right, so now you can see that the osmolality of ultrafiltrate inside the ascending limb, loop of Henle, is decreasing, right? The osmolality is decreasing in terms of the number because the particles is lost, okay, being excreted out. The dissolved particle like the sodium and chloride leaving the tubules, because we still, you know, need to reabsorb sodium and chloride for our normal activity inside the blood. Okay, so the thing is that the difference, if I ask you what's the difference between descending limb and the ascending limb, you can say in terms of the osmolality of the dissolved particles, sodium chloride, or maybe the concentration of water, or maybe you want to say about the structure, or maybe because of the permeability to the water. The left one, the descending limb, is permeable to water, but the right hand side, okay, the ascending limb is impermeable to water, but it is permeable to salts. Thick parts provides an active transport of the salt out of the filtrate. So this kind of giving a good space for the active transport to occur. And active transport of salt causes interstitial fluid to become hypertonic to the ultrafiltrate, thus they are leaving the tubules. Let's move on to the countercurrent a multiplier system. What is the countercurrent multiplier system? This is occurring in the loop of Henle. In other words, it's the process of using energy to generate an osmotic gradient that enables you to reabsorb water from tubular fluid and produce concentrated urine. And this is, you know, in other words, it's the countercurrent mechanism that is used to concentrate the urine in the kidney, all right, by the nephron. So this is how you want to make your urine is concentrated. Maybe it can only, you know, be can only contain waste molecules or unwanted materials. All right, so the things or essential components that you need, all of them, like water, sodium, chloride, potassium, glucose, amino acids, most of them need to be absorbed, okay, reabsorbed into the circulation, right? So the countercurrent multiplier system is a countercurrent flow and proximity that allow descending and ascending limb of the loop of Henle to interact in a way that cause osmolality to build in the medulla, right? So this is the balance or the interaction between the ascending and descending limb of the loop of Henle. If the body says that they need more water, so of course the descending limb need to reabsorb more water, and the ascending limb, you know, need to retain the concentration of the water. So this is like a feedback mechanism. They maintain the osmolality of the ultrafiltrates when they are inside the medulla of the kidney. Further, salt pumping in the thick ascending limb, they raise or increase the osmolality around the descending limb and causing water to diffuse out of the filtrate. It's more of creating a balance inside this loop of Henle. So that is the countercurrent multiply system. If one side is lacking water, the other side is try to retain some of water. If the right hand side is, you know, contain lots of sodium, the left hand side try to, you know, leave or try to excrete or reabsorb most of the sodium. So this is like a feedback mechanism where they want to sustain the concentration gradient. And this raises osmolality of filtrate in the descending limb, causes more concentrated filtrate to be delivered to the ascending limb, as I mentioned earlier. And this concentrated filtrate is subjected to active transport of salts and cause even higher osmolality around the descending limb. And this is called as the feedback, like the positive feedback of the kidney. All right, we move on to the Vasa Recta. What is Vasa Recta? This is the peritubular capillaries in the kidney that I've mentioned earlier, that is situated parallel to the loop of Henle. It surrounds the loop of Henle. It's kind of wrapping the loop of Henle and allow the transition or the transport of important component, water, like maybe sodium, into the capillaries. This is a combination. The vasa refer to the blood vessel. Okay, recta means straight. So a straight vessel, right? In other words, this is a capillary. They are straight arterioles and the straight venules of the kidney. You can see in the picture, the left-hand side is the, with the red one, that's the artery, and the right-hand side is the vein. Of course, if it's go to this point, okay, it's no longer artery and vein, but it's rather arterioles and also the venules of the kidney. All right, so don't get yourself confused. The artery and the veins are bigger diameter. So they are a series of blood vessels in the blood supply of the kidney that they, enter the medulla as the straight arterioles and then leave medulla to ascend or to, jump to the cortex as a straight venules. So there's always a change in terms of the concentration of the sodium or water or salt, right? Some amino acids in these capillaries. So you can see from the top in the capillary, blood flows, 300 goes in, and black arrows means diffusion of sodium and the urea into the capillary from the kidney, whereas the blue arrows, the movement of water by the osmosis. The changes of the concentration for these dissolved particles, they can change the concentration of the water, and it's really the balance that makes it work in a good way, right? Effects of the urea, that urea contributes to high osmolality in the medullary region. I've put in here the cortex and two regions of the medulla, the outer and also the inner medulla. Deep region of the collecting duct is permeable to urea and it is reabsorbed. Ascending limb absorbs urea, thus urea is trapped in the medullary region. Okay. You can see inside the picture where is the location where you can find the sodium chloride in green, urea in peach, and the water in blue. All right. So we start with the cortex. Most of them, sodium, urea, water enters the cortex area through the PCT. After that, they enter the descending limb, the thin descending limb, loop of Henle, outer medulla, and also inner medulla. Lots of water being reabsorbed. But at the junction, okay, at the U shape of the loop of Henle, where you can find that the urea being excreted or being secreted into the loop of Henle. Right, and then it travels up to the thick ascending limb where lots of sodium chloride being reabsorbed inside the outer medulla region, and after that the ultrafiltrate go to the distal tubules where most of the water still being reabsorbed, and again reaching the collecting duct. Again, water is still reabsorbed at that location. Other than that, if you can see at the loop of Henle and the inner medulla region where you can find the thick ascending limb, the sodium chloride is also roaming around inside this inner medulla or the deep region of the medulla, as well as the urea. So this is the, just to show you the deep region where most of the concentration, most of the concentrated particles are available. And that's the functions of the loop of Henle. Collecting duct, they play important role in the water conservation. Of course, as the name implies, you can see it's collecting, where it collects all of these materials or the fluids or ultrafiltrate from the neighboring nephrons, not only from the single nephron, but it can join a combined from a multiple nephron, right? So one collecting duct, one set of collecting duct can join maybe another 100 nephrons altogether. So it collects from 100 nephron at a time, for example, and they try to conserve the water as much as they can. Conserve means they want to still reabsorb the water into the circulatory system. They don't want the water to leave the system. Right, so it is impermeable to salt, means they don't allow salt to leave the tubules, and permeability to water depends on the level of antidiuretic hormone or vasopressin. All right, so the regulation of the collecting duct or this tubule is regulated by the hormonal control, right, as well as its own permeability or membrane potential, or the membrane capability to allow a certain amount of salt to pass through. So the antidiuretic hormone secretion and action, I've put it here. If it's increased osmolality in the case of dehydration, of course, when you are dehydrated, for example, during fasting, you can find that you are in a state where you have a reduced amount of water, and reduced amount of water means your concentration of particle is high. So higher concentration of particles leading to increase in osmolality, right? And the receptors involved is that osmoreceptors in the hypothalamus. They can sense this when you are in the state of dehydration and your concentration of particles is high. So your hypothalamus start to get the signal, and the ADH secretion is increased. And this can act on the urine and the kidney by decreasing the amount of urine being secreted. And not only that, the vasopressin also has some effect on the blood, and it causes increased water retention and decreased blood osmolality. Increased water retention means they don't allow the water to leave the system as urine, right? So they retain lots of water inside our body, right? Because if you are in the fasting mode, if you are urinate frequently, so you don't have anything else, right? You become dehydrated, and maybe that can lead to the hypertension. So it's also lead to decreased blood osmolality. So the concentration of the particle in the blood is decreased, of course, because they still have the water in it, right? This is regulated by the antidiuretic hormones or the vasopressin. In the case of more water, also your system can detect this, which is the osmoreceptor in the hypothalamus in the brain. All right, if you, in the case of a high blood volume, so the ADH doesn't need to be secreted at a good amount, okay? So it's try to compensate this by secreting a lower amount of ADH, but then you will urinate more frequently because your body have now lots of water. So the effect of blood is that the water loss, they will increase the osmolality. If you excrete more water, means your blood concentration will become increased, all right? And not only that, the collecting duct also means affected by these antidiuretic hormone secretion via increasing blood volume. Okay, if you have an increasing blood volume, there is some receptors on the heart. Okay, we call these stretch receptors in the left atrium, And it can also reduce the amount of vasopressin being secreted, and then the urine will become more to be excreted, and finally it decreases the blood volume. On the other hand, if the system signals or receive a signal saying that, okay, your blood volume is low, so the stretch receptor in the left atrium again or what we call react to this reaction by secreting more ADH, and more ADH means you will decrease the amount of urine, and after that it will increase the blood volume to the normal level. So this is one of the functions of the ADH. If you want to understand a bit further, this is only the explanation just to see the feedback correction or the feedback mechanism of antidiuretic hormone. How does it functions in regulating the water retained in the system? ADH is secreted by the posterior pituitary in response to the hydration. Okay, look at the left-hand side of the illustration. It stimulates the opening of aquaporin, that is the water channels at the collecting duct region, not in the PCT, DCT, or LOH. When ADH is high, water is drawn out of the collecting duct by high osmolality of the medullary interstitial fluid, as I mentioned earlier, and then reabsorbed by the Vasa Recta. Okay, same like the previous slide. If you are dehydrated, of course, your blood plasma osmolality is high, and this can give a signal to the osmoreceptors in the hypothalamus, causing the pituitary to release more antidiuretic hormones, and that will act on the kidneys to increase the water reabsorption, increase sodium or water being retained, and further less frequent of the urination. But in the case of too much water, if your system is receiving a higher water intake, means you drink a lot, maybe 10 liter, maybe 20 liter. Okay, I don't know whether your body can tolerate this or not, but it will decrease the plasma osmolality. The concentration of the particle inside the blood plasma will decrease. And again, this will be detected by the osmoreceptors in the hypothalamus, causing the posterior to release low amount of the ADH. Low amount of ADH will act on the kidney and tell the system or tell the kidney to urinate less. To urinate more, because you need to release more water from the system. All right. In other words, the antidiuretic hormones, they regulate the amount of water in your body. Right? It works to control the amount of water in your kidney that your kidney reabsorb as they filter out waste from your blood. In some cases, this hormone is also called the Arginine Vasopressin or simply vasopressin. There are lots of examples of antidiuretic hormone out there. Okay, and this is important for action on the kidney, where they increase the reabsorption of water. And you know that the vasopressin initially been named as the vasopressin because it related with the vessel. It is a potent or powerful vasoconstrictor. It can cause the blood vessel to constrict, and its effect are through the two types of receptors. I'm not sure whether this is important for you. We call it the V1 and V2 receptors. All right. Of course, the antidiuretic hormones, they will act on the kidney tubules. Of course, this is the smooth muscles in the arterioles. All right. And in the hospital, sometimes people used to give you the vasopressin injection. This is to control the frequent urination, increased thirst, and loss of water caused by the diabetes. All right, this is the condition that causes the body to lose too much water and then become dehydrated. Right, so in the hospital, you use the vasopressin injection to control the urination rate. Okay, how frequent the people urinate. If it's too frequent urination, of course you don't want this to happen, so you will inject this vasopressin. In the case your own vasopressin is not working well, or you have any hormonal imbalances, or maybe brain problem at the hypothalamic area. Renal clearance refers to the ability of kidney to remove substances from blood and excrete them in urine. Occurs by filtration and by secretion. Secretion is opposite of reabsorption. Substances from Vasa Recta are transported back into the tubule and then excreted into the ureter. Reabsorption decreases renal clearance. Secretion increases the clearance. All right, again, this is another feedback mechanism. There is some parts of the tubules that reabsorb the water, sodium, or important molecules. At some point, towards the end of the tubules, most of them being secreted back into the kidney tubules, right? So this is very interesting. Reabsorption, occurring at the PCT, some at the loop of Henle, and the secretion towards a later stage of the tubules like the DCT and collecting duct before it will be excreted as urine. So that is the renal clearance. In other words, excretion rates equal to the filtration rate plus secretion rate minus by reabsorption rate. This is only the formula. This is an example for you to illustrate the functions of inulin, all right, not insulin. This inulin is another analog or molecule for the sinisterine, but we use this inulin to help to measure the kidney function by determining the glomerular filtration rate. So we use this inulin just to measure, right? This is the gold standard to measure the GFR, because inulin, has all the properties of the ideal marker, right? It's freely filtered by the glomerulus. It's not secreted or reabsorbed in the tubules, and it's not synthesized or metabolized by the kidney. Okay, so we just give this to check how well is your kidney working, right? So this is related with the GFR. You can see from the top left corner of the picture, you can see inulin in green particle entering the afferent arterioles. You can see the lumen of the afferent arterioles a bit bigger than the efferent. So you can see the inulin entering. After that, it being filtered into the PCT, and some of them live into the peritubular capillaries through the efferent arterioles. So since it's not reabsorbed or nor secreted, the amount of inulin in the urine is exact indication of the GFR. So whatever amount that you put into the kidney or passing through the afferents or glomeruli, the same amount should leave the kidney. All right, this is to check, to measure how well is your kidney function. Renal clearance of a molecule also secreted. The PAH. PAH is the para-aminohypurate clearance. Okay, para-aminohypurates is another way used to to check or to measure the renal plasma flow. Again, this is to measure the renal function, same like the inulin, but it's a bit different. The PAH is filtered by the glomeruli and is actively secreted by the proximal convoluted tubules. And, we usually use this PAH, in combination of the inulin clearance to determine the, both GFR for the inulin and the renal plasma flow for the PAH. So you know that the GFR changes developing before onset of renal injury indicate probability of the prerenal or hemodynamic factor in the course of the renal injury. So try to mention or try to measure what is the current status of your kidney, whether you can allow some molecules or you may have lose some of your kidney function. So in the C, you can see the PAH molecules being filtered. Some of them are leaving the peritubular capillaries and then enter the renal vein. Some of them being secreted in the tubules. But that's not the case for the inulin. The inulin doesn't be secreted back into the tubules, and they will be secreted as urine. Glucose and amino acid is also another important molecules that is involved during reabsorption, quite early stage in the PCT, and the filtered glucose and amino acids normally completely reabsorbed from the ultrafiltrate. Okay, this is at the PCT stage. And occurs, of course, this occurs in PCT by co-transport with the sodium. Right, sodium, chloride, potassium, glucose, amino acid, bicarbonates. What else? All of these being reabsorbed again back into the capillaries. Transporter displays saturation if ligand concentration in ultrafiltrate is too high. It's true. Level that saturates carriers and achieve maximum transport rate is the transport maximum. So the transport maximum for glucose tubular transport system in adult system is around 375 milligram per minute. And when we call the transport maximum, it means that it is the maximum rate of secretion, or maybe a maximum rate of reabsorption of a substance by the renal tubules. Okay, we call it the TM. In some books, they also refer this to the maximum amount of the substance that can be reabsorbed based on the number of transport protein available. This is also true. And glucose and amino acid transporters are not saturated under normal condition. All right, glycosuria means that is the presence of a glucose in urine, which is not good because you know that the glucose should be reabsorbed back to the circulatory system most of the time 100%. Okay, but in some people that have a renal problems, maybe something is happening like diabetes or hyperglycemic conditions, or maybe some tubules is not working well, maybe due to the age factor. So it can possibly retain some of the glucose into the tubules and then excreted in the urine, okay, together with the urine. And this is not good. It occurs when the glucose is more than 180 to 200 milligram per 100 ml of plasma. This is the renal plasma threshold, means that's the limit that the kidney can hold. Okay, the concentration of glucose that the kidney can hold. If it's exceeding that, okay, 200 mg, this is too high. Of course, the kidney cannot tolerate it anymore. Okay, cannot reabsorb back to the circulatory system, and eventually it can goes back to the tubules and excreted in the urine. In the normal condition, as I said earlier, glucose is not normally, present in the urine, not normally there in the urine, okay? Because the plasma levels stay below this level. In the case of hyperglycemia, it has to exceed the renal plasma threshold to cause glycosuria, like the one that I mentioned before. Diabetes mellitus occurs when chronic hyperglycemia results in the glycosuria. Other than that, you need to know that the kidney is not only for maintaining the blood pressure. Okay, you need to know that the kidney also have the other function, which is to maintain the acid and also base balance, right? And this is happening through the electrolyte balance, like the hydrogen ions. If there too much hydrogen ions inside your system, maybe it can cause acidosis or increase in terms of the acidity of the blood. On the other hand, if the bicarbonate level is high in your blood, of course, it can lead to the increasing basic, what do we call it, decreasing the acidity of your blood, right? So the kidney, on the other hand, it regulates the level of all these components, okay, all of these salts, sodium, potassium, electrolytes, hydrogen, bicarbonate, chloride, phosphate, by matching excretion to ingestion. Other than that, the kidney also control plasma sodium, which is important in the regulation of blood volume and also blood pressure. So I put it in red, so it's very important, means that's highly important. And the control of plasma of the potassium is also important for the working or functioning cardiac and skeletal muscles, okay? For the activity or for the filtration purposes, we need the sodium, we need the potassium to regulate this activity. The influx and efflux of the sodium and potassium are antagonizing each other, and they must be in balance. If it's inside the tubules, if the sodium is low, so the potassium most of the time will be high. Okay, so the control of electrolyte balance, we can see the role of aldosterone in the sodium and the potassium balance. Okay, you have learned this with me inside the hormone class last time. And we know that 85% of filtered sodium and potassium reabsorb before they reach the distal convoluted tubules, and remaining 50% is variably reabsorbed in the distal convoluted tubule and collecting duct according to bodily needs. This balance or this regulations was regulated by the aldosterone. It controls the potassium secretion and also excretion and sodium reabsorption or retention. In the absence of aldosterone secretion, some of the remaining 15% of sodium is reabsorbed in the distal convoluted tubules and collecting duct. And when aldosterone is high in circulation, all remaining sodium is reabsorbed. So that doesn't leave any more sodium in the system. All right, so there's more or less some of the functions or the role of the aldosterones. Basically, it's balance the level of sodium and potassium in your body. It signals to your organ like your kidneys or colons to put some more sodium in your bloodstream or release more potassium into your urine. So they regulate this. Okay, it depends on the activity or concentration of potassium and also sodium. All right, for the potassium secretion is the only way potassium is excreted in the urine, it is directed, of course, or regulated by the aldosterone and occurs in the late stage of the tubules like the DCT and the CD. High blood potassium or low blood sodium will increase production of aldosterone, and then the potassium secretion will occur. In the absence of the aldosterone, where your body cannot produce this hormone, all the potassium is reabsorbed and none is being excreted. Some people, when they have like a very high aldosterone, okay, for example, hyperaldosteronism, where both adrenal glands of on top of the kidney produce too much of the aldosterone, this can lower the potassium level and cause weakness to the muscle, or it can lead to the muscle spasm. However, this can be treated by the surgery. All right, so that's a bit of the aldosterone functions and how it's regulating the potassium and sodium concentration. About the electrolyte balance, is being controlled by a special structure of the kidney. We call it the juxtaglomerular apparatus, or JGA, and it is a specialized region in each nephron where afferent arteriole comes in contact with ascending limb and the distal convoluted tubules. All right, so they have a three component here. We have the arterioles, okay, the afferent arterioles, plus the ascending limb, and also the distal convoluted tubules. All right, three components. Okay, there is where they are being, combined together at the same location. Now, this is not frequent. Okay, some of these, we can find, but most of them are not like this. Okay, but this is important for regulating the electrolytes balance. You can see the clear structure of the glomerulus on the right hand side. We can see the afferent arterioles. You can see the blood cell in it. And after that, underneath, you can see the granular cells and the macula densa of the thick ascending limb. That is the place where we call it as the juxtaglomerular apparatus. It's the joint component of the kidney. And this is another topic. I think this is also important for you as the future clinical nurses. You need to understand how the body controls the electrolyte balance by manipulating the renin, angiotensin, aldosterone system. We have lots of components here. Another word, we call it the RAS system. All right, this is the long-term system. Other than that, your body have a short-term to regulate the electrolyte balance. As I mentioned earlier, the short-term is using the hormone aldosterone. But for the renin, angiotensin, aldosterone system, this is a bit more longer period, okay, for the long-term reactions. It begins by the release of the renin from the granular cells of the afferent arteriole due to low blood volume and also the low blood pressure and the low flow in the afferent arterioles. On the afferent arteriole, as I mentioned, where most of the blood vessels have these special baroreceptors that they can sense or they can detect if there's anything happening or any changes is detected in terms of the flow or the speed, velocity, in terms of the pressure of the blood. So the body or the blood vessel can directly, detect this condition. So they need to react this by triggering the activation of the RAS system. The RAS system begins by the activation or by the release of the renin. The renin is a component. The renin is a component being released by the granular cells of the afferent arterioles okay? And the renin have the capability, the renin be released by the kidney, of course, the granular cells of the kidney, and these will have the capacity to convert the plasma angiotensinogen in the liver to angiotensin 1. So this is the first mechanism that is occurring in order to activate the RAS system. The renin being produced by the kidney, which is granular cells, and this renin is being used to convert angiotensinogen inside the liver, all right, into angiotensin 1. Okay, this is the step. So now you have angiotensin 1. The angiotensin 1 needs to be converted into angiotensin 2 by the angiotensin converting enzyme. We call it as ACE. This is available inside the lung endothelium, all right? So the ACE enzyme functions to convert the angiotensin 1 into angiotensin 2. All right, so once you have this angiotensin 2, this is the most important key player inside the RAS system. Angiotensin 2 have several activity or have several functions to control the electrolyte balance in our system. The first one is that the angiotensin 2 is able to cause the vasoconstriction, and of course this involves the systemic circulation, where the vessels need to constrict. Why? Because you have known from earlier slide, or from this slide, I think, due to the low blood pressure, okay, and also the low blood volume. Of course, your body reacts by increasing the production of angiotensin 2 to vasoconstrict. Right, this is occurring in the systemic system. When the blood vessel constrict, of course, you have a higher blood pressure. Other than that, the angiotensin 2 can also stimulate the kidney to retain more water and more sodium. All right, more sodium, more water will be retained inside the kidney. And not only that, the angiotensin 2 also can stimulate the aldosterone through the hormones. As I mentioned earlier, this is the short term. All right. It can stimulate the aldosterone, which is being secreted by the adrenal gland on top of the kidney, to again allow sodium and water to be retained in the kidney. So inside this slide, I put it, the angiotensin 2 or angio2 stimulates the release of aldosterone from the adrenal cortex. Aldosterone then stimulates the sodium reabsorption, means sodium being retained in the circulatory system. Most of them being reabsorbed from the kidney into the circulatory system. Chloride and water follows, and then the final effect is that the blood pressure is increased. So this is, the most important mechanism why, how we can retain back our blood pressure. And this is control of electrolyte balance. Another slide just to recapitulate what we have discussed earlier. It's a region, macula densa cells is a region of ascending limb in the contact with the afferent arterioles. And of course, it works opposite to the RAS system, okay? For each system we have in the body, it's not only RAS, all right? It's true for most of the other mechanism as well, where we have this feedback mechanism to maintain. If there's any increase of certain amount for certain component, there must be some compensation mechanism where they can reduce this amount. So there's always a feedback mechanism to sustain our body. So in this case, we have these macula densa cells that works opposite to the RAS activation. Okay, they respond to the level of sodium in the ultrafiltrate They inhibit renin production by the kidney, okay, and it causes less aldosterone secretion, and then it can lower the BP. All right. On the other hand, so this is on the other side. If your body or if the afferent arterioles, have detected very low blood pressure, right, your body need to undergo or activate the RAS system to increase the blood pressure again. But in this case, this is the macula densa cells that functions to react to the level of sodium in the alpha filtrate by inhibiting the renin production of the kidney. So no more angiotensin 2 being secreted. No more angiotensin 2 means no more aldosterone, no more water or sodium being retained in the kidney, no more vasoconstriction, right? This is an example to illustrate the sodium intake. So if you have a low sodium intake, and that leads to the low plasma concentration in the blood, and this can be detected by the hypothalamus that triggers the posterior pituitary to reduce the production or secretion of antidiuretic hormones. Decreased ADH level leads to decreased water reabsorption in the collecting ducts, hence more urine will be produced, but then the blood volume will become low. And low blood volume, again, as I mentioned earlier, in the RAS system, it can be detected by the sympathetic nerve activity. This is the fight or flight response. This is important for your body to detect any changes in the blood volume. If not, you will die. So this has been detected by the central nervous system, particularly the sympathetic nervous system or the fight or flight system. It will be innervated or activated and can be sensed or be detected by the juxtaglomerular apparatus of the kidney. So the JGA again functions to detect these changes in the blood volume or blood pressure. And again, they are activating the RAS system. They will start to increase the renin, okay, that converts angiotensinogen in the liver to angiotensin 1. And after that, the ACE enzyme will convert angiotensin 1 to angiotensin 2. And angiotensin 2 will stimulate the aldosterone production by the adrenal cortex, and that's increase the aldosterone level inside the system. And after that, they will increase sodium reabsorption in the cortical collecting duct, and more sodium will finally retain in the blood. So this kind of summarize what I've been talking just now. Other than that, we have another component or factor, we call it atrial natriuretic peptide, or ANP, is produced by the atria due to the stretching of the heart walls, and it acts opposite to the aldosterone on the kidney, right? It stimulates salts and water excretion. So it's antagonized the activity of the aldosterone, and it acts as a diuretic and at the same time as the natriuretics, all right? The ANP is a cardiac hormones, of course, being produced by the atria. That gene receptor is widely present in the body, okay? The receptor, not only in the heart, it can be some other smooth muscle cells or in another organ in the body, right? And its main functions is to lower the blood pressure and to control the electrolyte homeostasis. So the ANP, they antagonize the activity of the aldosterone, right? ANP also prevent the sodium reabsorption by the renal tubules and decreasing the water reabsorption. That's why we call it as diuretics. And at the same time, it's lowering the blood pressure. It suppresses the action of aldosterone. It suppresses the action of ADH. it suppresses the action of the renin as well. Okay. Is it too much? What time we're gonna end? I think we already finished around 1 hour, but I think just a few more slides to recapture what we have learned so far. So this is the sodium, potassium, and hydrogen ion relationship. You can see that the sodium reabsorption in the DCT and CD creates an electrical gradient for the hydrogen ion and potassium secretion. And potassium in the blood can cause acidosis. We call it hyperkalemia because the potassium is secreted at the expense of the hydrogen ion. So it's been together, okay? It's kind of, if you have a higher potassium level in the blood, it can also bring the hydrogen ion together. And that can lead to the a condition or where lots of hydrogen ions or acids, okay? Hydrogen ions means acidic prone inside the system. So you can find that your blood is full with the hydrogens and that can cause the acidosis. In severe acidosis, where hydrogen ion is secreted at the expense of the potassium, they can result in the hyperkalemia, right? In the case of acidosis, the lots of potassium also being secreted in the tubules. Renal acid-base regulation, as I mentioned earlier, your kidneys not only functions to regulate the blood pressure, but it's also for balancing the acidity or acid base. The kidney help regulate blood pH by excreting hydrogen ions or reabsorbing bicarbonate ion. And most hydrogen ion secretion occur across walls of the proximal convoluted tubule in exchange for sodium reabsorption. Normal urine is slightly acidic, but if you have alkaline or basic urine, it can be some other condition where you can find higher concentration of bicarbonate. Diuretics, another interesting topic in the clinics or in the hospital where we use diuretics to lower blood volume. This is based on our knowledge of the activity or based on the capability of the tubules to absorb or receive the secretion of the ultrafiltrate from the circulatory system. Not ultrafiltrate, what we call, if it's from the circulatory system, it's receiving water or another sodium, right, or blood plasma materials. So diuretics are used to lower blood volume because of hypertension, congestive heart failure, or edema. It's all related with the water, isn't it? So increased volume of urine by increasing portion of glomerular filtrate that is excreted. All right, so this is diuretics. Some people say it's water pills. They are, type of medication to increase amount of water and salt being excreted from the body as the urine. And most of them, being classified as a 3 type of prescription diuretics. And they most commonly help to maintain, or to treat high blood pressure. But not only that, they are being used for some other condition. The most condition being is the high blood pressure, and the drugs or diuretic reduce the amount of fluids in your blood vessel, and this will help lower your blood pressure. Under condition like the congestive heart failure, is like I mentioned earlier, it will keep the heart, from pumping blood effectively throughout your body. Okay, it keeps your heart from pumping blood effectively throughout your body. And this leads to a buildup of fluids in your body, which is called the edema. And diuretic can help reduce this fluid buildup, right? Some books, they mention 4, some books mention 3 types of diuretics. But let's have a look at these loop diuretics. Loop diuretics are the most powerful. They inhibit the active transport of salts in the thick ascending limb of the loop of Henle. Thiazide diuretics, they inhibit the sodium chloride reabsorption in the first part of the DCT. Potassium sparing, they reduce fluid levels in your body without causing you to lose the potassium, which is an important nutrient. Carbonic anhydrase inhibitor that prevent water reabsorption in the PCT when hydrogen carbonate is reabsorbed. Osmotic diuretics increase osmotic pressure of the filtrate. For the diuretics like the loop of loop diuretics, most of them used to treat the heart failure. For example, you have the torsemide, furosemide. Furosemide, I think, is most common. You can see in this picture at the thick ascending limb, you can see that the furosemide sensitive area. So that's where the furosemide will act on. In the clinic, I think you came across another brand name. We call it Lasix. Lasix is a type of furosemide considered under a loop of diuretics. Thiazide, the most commonly prescribed, I could say, they're the most often to treat the hypertension. People with the hypertension, commonly you use these diuretics because you want them to, excrete more water, okay? So that the blood pressure will reduce. The drug not only decrease the fluids, but also cause your blood vessel to relax, okay? And sometimes taken into, in combination with other medication, right? I can name a few thiazide groups: Cortalidone, hydrochlorothiazide, metolazone, and indapamide. So this is the most common thiazide being used in the clinics. Potassium sparing, as I mentioned earlier, you don't want the potassium to leave the system, but still you want to reduce, the fluid level in your body, but retain the potassium. Other types of diuretic can cause you to lose potassium, that can, leads to the arrhythmia. Potassium sparing diuretics may be prescribed for people at risk of low potassium levels, such as those who take other medication that reduce the potassium. But the potassium sparing diuretics, they don't reduce the blood pressure like the other diuretics, okay? So therefore, like maybe the doctor prescribe you potassium sparing diuretics with, combination with another medication that also can reduce the blood pressure. If I can name a few potassium sparing diuretics like amiloride, trimterene, spironolactone, and eplerenone. But you need to know that not all people, tolerate with the diuretics, because it can cause some side effects, like, you will have like very low amount of potassium in the blood, and this is very dangerous. You need the potassium for the activity of your muscles, for the normal regularity of your activity of your smooth muscle, muscle, what else, some other organs, blood vessels. So it's important. But if you lose this through, taking or prescribed diuretics, you need to cover it back. Okay, you need to, of course, replace the potassium that is lost. So you need to monitor the potassium level at all times. Another side effect is that if you take the diuretics, you will have low sodium level. This is true. You will have symptoms like headache, dizziness, dehydration, rashes, diarrhea, and this is common, but it can also lead to like a serious side effects like allergies, kidney failure, or arrhythmia. So you need to have like a, consultation with your physician before you take any types of diuretics. People with some conditions, they are not allowed to take diuretics, like diabetes, people with lupus or kidney problems. They can do, but always need to consult the medical doctor before you take this. All right, I think that's it for today. For you to go back and try to find out what are the other possible activities of the diuretics, it can help you to understand a bit more on the system. All right, everyone, I think I will just stop up to here. This is part 2. So of course, next week, try to find one time where we all can have the quiz that combine the part 2 and part 1 altogether. It can be 15 questions, MCQ through iTatlim, or maybe 20, 30, not sure, but you decide. Okay, find one time where everyone is available to have the quiz. Thank you very much. I will stop up to this point. I will provide the slide to your group section. If there's anything you want to ask, if that is not clear, so try to contact me through email or through your group section. I think that's it for today. Let us close the session. Let us end the session by recitation of Tasbih Kafarah and Suratul Asr.